Hello and welcome once again to our channel Steer by Dr. Amdekar's team. I am Dr. Tushar Maniar, pediatrician from Andheri, and I'll be talking to you about interpretation of ataxia today. Ataxia denotes disturbance in fine control of movement and posture and is caused mainly by affection of cerebellum and sometimes with affection of spinocerebellar tracts or because of faulty input from bifrontal lobes. Now patient comes to us not with complaints of ataxia but usually comes with complaints of either loss of balance or inability to walk properly. We must remember that cerebellum is not the only organ responsible for balance. We require good power, a proper tone, that means no hypotonia, hypertonia. We require good coordination, appropriate vision, a good spatial orientation and communication between different parts of the brain in order to maintain balance and to have a proper gait and fine motor coordinated movements. Now when we get a patient with loss of complaint, we must first rule out other conditions which may result in loss of power or cause hypotonia, or conditions like vertigo which may result in imbalance but are not typically ataxia. Patient may complain of falling. Now that could be because of syncope. So we must get proper details and see whether there is only a complaint of falling or whether there are other symptoms which are usually associated with ataxia as part of the cerebellar affection. What are we talking about? We are saying if there is scanning speech, if there is dysmetria, if there is hypotonia, or if there is difficulty in reaching out for object, if there is tremulous movements, if there is poor handwriting or loss of fine motor movements, all these things usually are present. If not all, most of the things are usually present, and loss of balance is not the only complaint in a patient with cerebellar disorder. When we talk of ataxia, we generally like to divide them into acute ataxia or recurrent ataxia and into chronic or chronic progressive ataxia. The commonest causes of ataxia, acute ataxia, are drug ingestion, substance ingestion, and post-infection cerebellitis. That means the classical case being post-chickenpox cerebellitis. With recurrent or intermittent ataxias, there could be recurrent exposure of drugs. It could be certain conditions like multiple sclerosis which can present as recurrent episodes of ataxia, and there are certain inborn errors of metabolism as well as rare inherited ataxias which can be intermittent ataxias. When we talk about ataxia, the commonest cause is cerebellum, and when we approach, we want to look at whether the vermis is affected or the cerebellar hemispheres are affected. And the important difference is in vermis, the patient usually will have either a to and fro movement of the head or of the body and what we call as titubation or head nodding. On the other hand, with cerebellar hemispheres affected, they usually have swaying on the affected side. When they walk, they will have difficulty in reaching out for objects. They will have intention tremors more on the affected side. And they will also have dysmetria, hypotonia, and sometimes slightly depressed deep tendon jerks on the affected side. Once we are thinking about non-cerebellar causes of ataxia, we are looking at spinocerebellar tract. So how do we decide on history or examination? Because there is lack of sensory input from the spinocerebellar tract, patients would be classically constantly looking at their feet while walking in order to judge the distance between their feet and the floor. They will have stamping or marching gait. They may have wide base gait, but the swaying or the lurching which is classically seen with cerebellar involvement is missing in spinocerebellar tracts. Also, we all know the classical Romberg's test, in which the patient can maintain their position with eyes open but are not able to maintain once the eyes are closed, is a classical sign of spinocerebellar ataxia. Also, these posterior columns conduct vibration as well as position sense. So when you check them for vibration or position, you will get an abnormal result there. It is also interesting to know that affection of spinocerebellar tract, the fine finger movements are more affected than reaching out for an object is affected. We also should know, just as we discussed, that in ataxia, just as we said that ataxia is not usually the only presentation of cerebellum, we must remember that ataxia or other cerebellar signs could be part of a larger CNS or a neurological problem. And hence, in every case presenting with ataxia, a detailed CNS examination as well as history is extremely important. To give you an example, a child with ADEM may present only with ataxia, and on examination we will get white motor signs which are patchy and asymmetrical. Also, we know that autoimmune encephalitis like NMDA encephalitis presents many times only with ataxia. Chronic progressive ataxia or acutely progressive ataxia with signs of raised ICT, one should think about hydrocephalus or any other space occupying lesion, especially in the posterior fossa. When we are talking about stroke, also when we get history which is acute or sudden, we must think about a basilar stroke which can occur after a chiropractic maneuver, sports trauma, or sudden extreme extension of the neck, which may cause thrombosis, and within minutes or hours one can develop a basilar stroke which can present only with ataxia. So along with this, many of the chronic progressive cerebellar ataxias are hereditary in nature. And so if you get a child who has history of ataxia but also has scoliosis and high arch feet, and there is a family member affected, one would quickly try to make a diagnosis of Friedreich's ataxia. Similarly, the whole gamut of spinocerebellar ataxia presents as neuroregression or chronic progressive ataxia in children, and there will be a family history present in these conditions. If you have a child with ataxia, we should not limit ourselves to only this, but we must do a complete examination and rule out other associated features, because some of the multi-system diseases can present as ataxia. To give you some examples, if the child has history of failure to thrive, large stools, bulky oily stools, and develops ataxia, you are thinking probably in terms of A beta lipoproteinemia. Similarly, a child with multiple infections in early childhood with some eye changes and skin affections, one could start thinking in terms of ataxia telangiectasia. Lastly, we should remember that occasionally, especially in adolescents, we can have psychogenic causes of ataxia. And one way to differentiate would be that they present with exaggerated symptoms and signs. They perform extremely complex movements which actually require very significant coordination, but they complain of lack of control and balance. Also, when we do repeated examination, usually the complaints in psychogenic ataxia are variable. So finally, to conclude, friends, when we have patient with ataxia, it's important to rule out other causes of loss of balance, confirm that there are other signs along with ataxia to call it a cerebellar disorder. We discussed how to differentiate between vermis and cerebellar hemispheres. And in spinocerebellar affection, we would get Romberg signs positive, Along with that, we will have position and vibration sense affected. And we have decided not to stop short by doing cerebellar examination, but do a detailed CNS as well as take a detailed history, including family history, in order to find if there is any multi-system disease association. Thank you, friends, once again for your patient hearing. See you next time.